Hello, my name is Mort Kern. We're here at the University of California at Irvine in the cardiac cath lab, and I'm going to take you through a three-part discussion of radiation and radiation safety in the cath lab. This will be an introduction to the physics and application of X-rays that we use in the cath lab to visualize angiograms and other structures during our procedures. So let's start right in. We're going to start here with the X-ray. So common X-ray image is obtained by injecting X-ray contrast material into the artery, seeing the luminogram of the vessel, and this image is generated through the application of X-rays originating under the table and transmitting up through the patient, reflecting off the iodine molecules and creating this image. All of this imaging requires the generation of X-rays through photons, and this requires the energy into the system in electrical volts. And we're going to see how the X-ray is generated. We're going to learn about the components of the X-ray generator. We're going to learn about the names given to the X-ray particles that form these images. First of all, let's look at and see how X-rays are generated. So a high voltage electrical current is put out of an X-ray generator, and this is all the different parts of the X-ray generator here on the left side. There's a transformer, an auto transformer, a high voltage transformer, and kilovoltages of electricity are generated, milliamperes of power are generated, and this electrical current is transmitted to the X-ray tube, which is here under the X-ray C-arm. We'll talk about this again in more detail. This is the X-ray tube. The X-rays are generated here. They travel upward to the image intensifier. Again, we'll go over this piece of equipment in detail. Let's just return a moment to the X-ray generator. The X-ray generator is pretty much automatically controlled, setting the kilovoltage and milliamperes of energy to produce an image. So there's a feedback system between the image generation and the power generation. Now this electrical current, a very high voltage, is transmitted through these big cables into the X-ray tube, which is a spinning filament of tungsten called the anode. The electricity hits the anode, it activates the molecules in the tungsten filament and produces X radiation. The electrical side is called the cathode, the tungsten filament rotating head is called the anode, and then there's a number of different components which make this high-speed rotational anode function well. There's a huge amount of heat generated by the transmission of electricity activating these electrodes, and that heat is taken out by this oil bath that surrounds this glass tube. Most of the energy used to generate X-rays, almost more than 90%, is taken out as heat, and only 3% of that energy remains to generate these X-rays. And there's a lot of different components that go into making this function very efficiently, very accurately, and very safely. Now let's look in a little more detail at the X-ray tube. So the voltage of electricity hitting the filament, this peak tube voltage, determines the maximum photons that come out. Now photons are those X-ray particles that generate the image, hitting and either being absorbed or being deflected. The number of electrons that make this jump across the cathode to the anode is called the current, and that force of driving these electrodes is measured in milliamperes. And then the size of the beam that comes out after those electrons hit this rotating filament generate a range of size of the beam, which we can call a focal spot, and it can be large or small. You can see that there are a number of mechanical components that go into making up this very complex tube, because it's a glass enclosed structure with the filaments, the bearings, the rotator, like on a light bulb, but a very big light bulb. And inside it are all of the different things. There's a vacuum envelope, a cathode cup, electrical filaments, there's a little window, the tungsten anode disc, the rotating system with bearings, rotators, and so on, and then the electrical connection for this. And then surrounding this is the cooling bath. Now, there are names given to the activity of these electrons and photons that cause the image, the X-ray image, to be generated. So this scattering of electrical activity in electrons and the breakdown of the nuclear particles has a name called the Bremsstrahlung. So this accounts for most of the X-ray generation, this breaking up of the nuclear particle. The electrons come close to the nucleus of this tungsten atom, which is on the filament, the anode filament, and it's caused these electrons to slow down and releases energy. So this gray line is the energy of the X-rays leaving this impacted nucleus of the tungsten filament. Now these X-rays have different characteristics. Some X-rays are of high energy, some X-rays are of low energy, and it depends on which of the electrons were knocked out of their shell to cause this effect on X-ray generation. The X-ray is formed from the excess energy released when the shell electrons in the K, L, M, or N move to another shell. And this is the whole image here is the tungsten nucleus on that rotating anode. So let's just review how these X-rays are generated. An electron hits an electron in an outer shell of the tungsten nucleus. The inner shell electron is released, creating an opening, and that outer electron then falls into an inner shell layer, and that movement from one shell to the other is what releases the X-rays that we capture and move through the patient. Now, sometimes these X-rays are attenuated or diminished as they travel up from the bottom through the patient. So the degree that an X-ray beam is diminished or attenuated will depend on the force of the X-ray or the photon energy of that X-ray. Now that X-ray energy again depends on the atomic number of the object through which it travels and the density and thickness of that object. So that all contributes to image and X-ray attenuation. Now sometimes the X-rays don't travel in a straight line, they get scattered, and thus their effectiveness is reduced. Compton scatter is the normal movement of these electrons and X-rays, not in a straight line, but from bumping into different things. So the main interaction for the process in generating diagnostic X-rays in tissue and the cause of most stray radiation in the cardiac cath lab is from this scattered X-ray activity called Compton scatter. Now, the reason we can use X-rays to see different things is that certain energies of these photons have a cohesive or a singular peak, and that this photoelectric effect permits us to use X-rays to look at one set of tissues and have it differentiated from another set of tissues, or from iodine versus a non-iodine filled structure. So this sudden increase in the amount of radiation absorbed by a different material, such as iodine, whenever a fixed threshold of energy is exceeded, is called this photoelectric effect. And they can define these as an edge for iodine in this case, which is what we use as the contrast material to generate X-rays and images that differentiate the X-ray from tissue. Now let's just talk for a minute about X-ray dosage. Dose is a measure of the amount of X-ray energy absorbed from the radiation field by a volume of tissue. So we need a certain amount of X-ray to penetrate tissue. It's a measure of the concentration of the energy absorbed by the tissue, and it's due to the interaction of these X-rays with the tissue atoms. And it is the result of the X-ray photons that enter and are absorbed and do not exit that create this dosage effect. So X-rays that are absorbed into the tissue are what we really worry about. Are we getting enough to produce an image and not too much to produce harm? So how do we measure radiation? Well, we have several different names, and there is some difficulty in keeping some of these straight. I'll see if I can make that clear for us. We have the absorbed dose, the effective dose, the air kerma dose, the exposure dose, and an equivalent dose. And we'll cover all of these in just a moment. It's of interest that we are provided with different markers and indicators of our radiation dose right on the imaging field screen. And I'll show you a picture of that on one set in which we can follow along our X-ray doses during the procedure. So let's talk about the absorbed dose first. This is a measure of the amount of X-rays that are absorbed. It's measured in the nomenclature unit gray. 1 rad is equal to 10 milligray, and we don't use the term rads for this. Absorbed dose is the amount of energy locally deposited in the tissue per mass of tissue. It measures the concentration of energy deposition in this tissue, and it's useful to measure the biologic risk in exposure to X-ray. When we talk about the effective dose, this is the amount of radiation measured in sieverts, and it replaces rems. 1 rem is equal to 10 millisieverts, and this is the dose given to the whole body that produces the same stochastic risk. Now, stochastic risk is the prediction of an event happening down the line. It's different than the deterministic risk, which is the amount of X-ray that can produce tissue damage, sort of more threshold. But this is the overall risk of developing, say, cancer in the future. This effective dose is the translation of the absorbed dose to a limited portion of the body. It converts any localized absorbed dose or equivalent dose to a whole body risk factor, and it allows for a comparison between individuals exposed to X-ray for whatever risk they might have. So it gives us a sense of how much risk for how much dose for the individual's future activity as he goes through his career in the cath lab. Now, air kerma is another method of determining how much radiation we've used. It's measured in grays. It's the sum of kinetic energies of all of the charged particles that the X-ray unit puts out in air, in a mass of air. It measures the amount of radiation at a point in space, and it's useful to assess the level of hazard of a specific location. So, for example, the point between the image intensifier and the fluoro tube, some intermediate point in space, we could determine what the dosage of radiation was in that. And if this was excessive, we would not want to expose patients or expose ourselves to such a dosage. So we use this to sort of regulate and determine exactly what the amount of radiation we're subjecting our patients to. It's different than the absorbed dose, and it's different than the exposed dose. So here's the exposure measurements. Measured in millicoulombs per kilogram. It's the total charge of ions, either positive or negative, produced by the radiation in air. And it measures the amount of radiation, again, similar to air kerma at a point in space, and it, similar to air kerma, is useful to assess the level of hazard at a specific location. So it's a second type of measurement than air kerma for exposure, telling us exactly how much radiation exists in a certain place during our procedure. Now, we're going to go one more measurement, the equivalent dose. This is the last one. Measured in sieverts, it's the dose quantity that factors in the relative biologic damage caused by different types of radiation. So this is a more direct or deterministic measure. It measures the relative dose that accounts for increased biologic damage that can occur when radiation hits tissue. And it's useful as the most common unit to measure radiation risk to specific tissues and determine the radiation protection of personnel. For example, our badges now are activated when we hit a certain radiation dose measured as the equivalent dose in sieverts. So this is a very helpful measurement for determining tissue injury or exposure that might cause tissue injury. Let's change gears for just a moment and talk about how contrast of an image is generated in the X-ray room. So if we had no differences in tissue density, that is, the 4 densities of air, water, blood, or muscle, and bone can be differentiated by X-rays, but they're very subtle differences. So in order to see structures well defined, we need to produce bigger differences in contrast. So we want to produce different image brightness between different portions of the heart. For example, the arteries versus the muscle, and the muscle versus the chambers. We can generate contrast using lower kV to get higher contrast. We can do the same thing such that the photos that reach the subject will be in this iodine absorbing kilovolt peak, and that the secondary X-rays which are generated, we would like to have those secondary X-rays reduced so we don't decrease our contrast, and that the problem with increasing contrasting generation with coning and narrowing and protecting of the X-ray beam so it doesn't produce as much scatter. So we want to produce X-rays at the lowest energy potential that produce the highest contrast and have the least scatter possible. So we use structures that filter X-rays so we don't have a lot of scatter and we don't have a lot of extraneous radiation. These filters are a means of removing low-energy X-ray photons that do not contribute to the image formation but contribute to patient exposure. We don't want that. And they cause hardening of the beam, focusing of the beam. Now, we talked earlier about scattered radiation. We talked about Compton scatter. But let's talk about what it does in practical terms. So here's a picture of the X-ray setup. Here's our monitor. Here's our patient. Here's our image intensifier. Here's our X-ray tube shooting X-rays upward. They come out of a cone that's focusing the beam. And if you see, most of the scatter of X-rays in the procedure come from X-rays entering the patient and being bumped off the bones or other tissues and scattered to the room. These scattered X-rays cause noise and image quality reduction. They're the principal source of exposure to everybody in the room, including the patient, because it goes in and bounces around. And the scatter increases with the size of the X-ray field, the width of the X-ray field, and the force of the X-rays traveling through the patient. So the faster they go, the more they scatter. The bigger the field, the more scatter. Now we use shielding around the operators and the team to prevent X-rays from scattering. And so this is one of the things that we should recall when we talk about radiation protection. Now the term noise of an image is used to describe an image that has a lot of different activity going on and the main contrast structure is obscured to somewhat. Noise results from fluctuation in image density produced by the small numbers of photons that we need to make the image, and these photons fluctuate. If you don't have enough photons flying through the structure, you get a noisy image. The amount of noise is inversely proportional to the exposure, so we want to have a high enough exposure to reduce noise, but not so high that we produce excess radiation. Now we can reduce noise by increasing the detection of photons through better quality image intensifiers, which we have, and increasing the number of photons produced by the kilovolt, which can automatically be detected in terms of feedback from the image to the generator. So we want to keep the noise down when producing high quality images.